Let's talk about lupus on step 1. 22-year-old woman, fatigue, joint pain, facial rash worsening with sun exposure, dark-colored urine, and look at this. Oh my goodness, look at that creatinine. Urinalysis, proteinuria, and blood. Holy goodness gracious. C3 is low, C4 is low, factor B is normal. Which mechanism is responsible? Okay, see if you can answer this question, and then we'll talk about it. Now, while you're thinking here, this person's got the lupus. It's a disease with autoantibodies, so anti-dsDNA. Anti-Smith as well, and it targets the self-antigens, forming immune complexes that deposit into tissues. Type 3 immune complexes. These immune complexes activate the classical complement pathway. Classical. That leads the C3 and C4 consumption, causing the low levels that we see here, and the alternative complement pathway is not activated, so factor B is normal. Factor B is totally normal. So there are 3 different pathways: classical, with the bacteria and IgG, alternative, C3, C3a, C3b, and the lectin pathway, the mannose-rich moiety. And all those will eventually lead to C3 convertase and then C3. And C3b is the opsin, and then opsin, and then C3a is the anaphylatoxin. So 3b, opsin, is the opsinin. 3a is the anaphylatoxin. Anaphylatoxin. Those are hard words to say. The opsinin is going to lead to C5 and then C5b, and then you get the MAC complex from 6 to 9. That's how it all works, right? That's the flow. Now look up a diagram. But the complement pathway, simplified, it's when you get a series of proteins that help the immune system clear your infections, right? And so you activate the G and the M binding. So remember, GM makes classic cars. That's the way to remember it. And it involves the C1 complex, C1q and R and S, and it cleaves CR and 2, and it forms C3 convertase. Leads to low C3 and C4 in SLE. So that makes sense, the classical pathway. Alternative, those are activated by spontaneous CB3 formations. Uses factor B and D, which are normal in SLE, and so the C3 levels will decrease, but C4 is normal because it's not used up in the classical pathway. And it would use B, but B is normal, so it's not that, not the alternative, because B is normal. The lectin pathway, mannose, okay? That cleaves C4 and C2 like the classical pathway, but it uses mannose lectin binding instead of antibodies. So the answer is going to be IgG and IgM because this is classical. SLE antibodies activate the classical pathway, consuming 3 and 4. Normal B tells us that it's not the alternative pathway. This leads to immune complex deposition, causing glomerulonephritis, arthritis, and skin diseases. IgA antigen binding is wrong. IgA is not even a complement. That's crazy, yo. B is spontaneous C3 hydrolysis. That's the alternative pathway, silly goose. B is normal, so what you talking about? C1 inhibitor deficiency that causes hereditary angioedema. Hereditary angioedema, complement levels in the hereditary angioedema, you have low C4 and normal C3. D, formation of the MAC complex. MAC complex destroys the bacteria, but it doesn't lower C3 to C4. That's downstream of the pathway. And so yeah, MAC defects cause Neisseria infections, not SLE. Now, last little note here. Med school is tough, but it's tough just because there's just so much you have to learn and so much time it takes to learn it. This is like learning the alphabet over and over again in like 25 different languages. It's just a bunch of buzz. And if there's a way you can jam it into your head and this channel is helpful, that's good. So hopefully you enjoy yourselves. Have a fun time out there. Life is so freaking short. Arguably too short for med school, but I don't think so. So hopefully you enjoy yourselves and learn something today about these mechanisms for complement activation systems for somebody who has SLE. Just know it's super classical. It's a beautiful thing. IgM activations causing the low C3, C4 levels. It's not alternate, the B cells. B factor is normal. So, okay. Hopefully that was helpful. We'll see you on the flippity flip.